today's episode of Myeloma Crowd Radio, a show that connects patients with myeloma researchers. I'm your host, Jenny Alstrom. We'd like to thank today's episode sponsor, Amgen, for their support of Myeloma Crowd Radio and all they do for multiple myeloma patients. Now, before we get started, I would like to share a way that patients can help change their own myeloma outcomes. Now, I just got back from a myeloma patient advocacy meeting, and what struck me was that patients who took charge to advocate for their own disease were better equipped at finding answers for themselves. And once they felt confident with that, they typically became advocates for us all, helping hundreds, if not thousands, of other patients. Now, I believe that we can't sit around and wait for a cure, that we can help accelerate our own cure, and many of my myeloma friends agree. So we have now joined together to create what we call the Myeloma Crowd Research Initiative. We started with a target for high-risk multiple myeloma patients, and as you'll hear in this show, our target may be equally effective for all myeloma patients. So with input from 6 leading myeloma doctors and 5 highly educated myeloma patients, and a very thorough review process, we've selected 2 critical projects that are immunotherapies that need our financial support. These are ways to use the immune system to fight myeloma, and one of the projects is a CAR T-cell immunotherapy, which you'll learn a little bit more about in today's show. And we invite you to help raise funds for these proposals by creating your own fundraising page that you can share with family and friends. So you can check out the myelomacrowd.org website for links at the top to create your own page and to help us fundraise for this very important initiative. So on the topic of immunotherapy, that is very tightly related to our project, is our show today. The University of Pennsylvania has really been leading the charge on CAR T-cell work, and Dr. Adam Cohen joins us to discuss this important work. So welcome to the show, Dr. Cohen.
Thank you, Jenny, and thanks for the invitation to be here today.
Well, we're thrilled to have you because you have some very exciting news to share. So we'll get into that in a little bit, but please allow me to introduce you first. Dr. Cohen is Assistant Professor and Director of Multiple Myeloma Immunotherapy in the Perelman School of Medicine at the University of Pennsylvania. He regularly lectures to internal medicine residents and hematology-oncology fellows and at hematology conferences. He's a member of the Oncology Evaluation Center Practice Task Force, the Clinical Trials Scientific Review and Monitoring Committee, and is a Clinical Advisory Board member for Managing Myeloma, which is an online educational resource that has extremely valuable videos for oncologists if you've never seen it. He is on the Cancer Immunotherapy Guidelines and Hematologic Malignancies Task Force, the Society for Immunotherapy of Cancer, and is a member of ASCO's Scientific Program Committee for Hematologic Malignancies. Dr. Cohen reviews journal publications from Blood, Amyloid, Clinical Cancer Research, Journal of Translational Medicine, Annals of Oncology, Cytotherapy, Leukemia, and Immunotherapeutics, in addition to many others. His most recent awards include Best Abstract in Myeloma, in Lymphoma and Myeloma at the International Congress on Hematologic Malignancies, the Fox Chase Leadership Forum Excellence Award, and the ECOG Young Investigator Symposium. He is a member of the Multiple Myeloma Committee of the Eastern Cooperative Oncology Group, which helps create and oversee myeloma clinical trials, and he is a scientific advisor for the well-loved Myeloma Beacon. So, Dr. Cohen, thank you so much for joining us.
Thank you for having me.
Now, we did a show with Dr. Alfred Garfall, who is in your group as well, and he gave us some insights about a project that you were working on, but at the time that we did the show, the final paper wasn't written. So we're going to be talking about that today, but maybe you want to just give us another refresher about the history of CAR T-cell use at UPENN and maybe just kind of a review of part of his show to start.
Absolutely, I'd be happy to. So probably many of your listeners are familiar with the concept of CAR T-cells since it's been a hot area in oncology lately, but just to briefly review, a CAR stands for chimeric antigen receptor. And basically the whole concept is trying to re-engineer a patient's own immune cells, usually T cells, to be specific for a molecule that's expressed on the surface of a cancer cell. And this technology actually was first developed over 25 years ago, but it's really only in the past 5 years or so that we're really starting to see impressive clinical responses. And so the CAR T-cell program at Penn has really been driven by a scientist named Carl June, who's been working on this for probably over 10 years now. And basically by improving the ability to get the CAR, or chimeric receptor, to persist in the T-cells, we've been able now to give this to patients with a variety of different cancers, and found that the CAR T-cells can survive and divide within the patients and actually try to kill off the cancer cells. And so the first studies at Penn were done in another type of bone marrow cancer called chronic lymphocytic leukemia, or CLL. And this study was led by David Porter here. And what they found in actually treating one of their very first patients who had extremely refractory disease was that patient actually went into a complete hematologic remission and remains in remission over 4.5 years later without any evidence of disease.
Wow.
So based on that sort of promising initial experience, we've now been treating patients with CLL as well as other cancers, one called ALL, acute lymphoblastic leukemia, and others called non-Hodgkin's lymphoma. And I should point out Penn is of course not the only place doing this. This is being done at Sloan Kettering and Baylor and multiple other centers around the country, and in fact around the world now. And what we're seeing is that with these chimeric antigen receptor expressing T cells, in particular these first CARs were against a molecule called CD19, that you're generally getting responses of between 40 to 50% of patients with CLL and non-Hodgkin's lymphoma, and responses in anywhere from 80 to 90% of patients with ALL. And so this really has been very exciting, particularly in those cancers, but for the field in general, and has led now to the exploration of using these CAR T cells in multiple other cancers, including multiple myeloma.
Okay, great. So it's seen as promising, and there was a review, and you brought it to myeloma, and then there was a recent article in the New England Journal of Medicine, and that talked about how you did use that. So do you want to describe how you used that in multiple myeloma and then what the outcome was?
Absolutely. So first, just to give, I guess, a little bit of the rationale behind the first study in myeloma, and as you mentioned, this study was actually led by Dr. Al Garfal here in conjunction with Ed Stapmauer and Carl June and the group here at Penn. So normally we wouldn't think initially of CD19 as being a typical target in multiple myeloma. Historically, if you look through the literature, CD19 wasn't thought to be expressed on the surface of myeloma cells. However, there's, I guess, a couple of hypotheses as to why we thought this might work in myeloma, and that led to the initial trial. And the first is that even though myeloma traditionally has been thought to be CD19 negative, there may be very low levels of CD19, of this molecule expressed on the surface of the myeloma cells, perhaps even below the limit of our usual ability to detect it. And we know that these CAR T cells, these re-engineered immune cells, are very sensitive to picking up even very low levels of a molecule on a cell's surface, so it's thought perhaps that they might work even if there was only very small amounts of CD19 on the myeloma cell surface. The second potential rationale is based on a hypothesis that, again, is still fairly controversial, that there may be precursor cells that give rise to the bulk of the myeloma cells in a patient, and that these precursor cells are actually CD19 positive, that they are living in a population of the patient's immune system that are called B cells that normally are precursors to normal plasma cells, and in this case the thought is there might be a malignant myeloma precursor cell that expresses CD19 that gives rise to most of the myeloma, and actually maybe a source of resistance to most of our commonly used therapies. So the thought was perhaps if we could target that with these what we call CART19 cells, these T cells that are specific for CD19, that maybe you could eradicate that myeloma precursor and help extend the duration of remission. So with that rationale in mind, this trial was designed. And basically it was specifically for patients who had previously been treated for their multiple myeloma with an autologous stem cell transplant. And their disease had come back in less than 12 months after the transplant. And this is a difficult situation because patients whose disease comes back in that short time frame often have more aggressive relapse and may be difficult to get long-term disease control. So these patients, most of them had undergone other therapies to try to keep their disease in control after they relapsed. And then when they came onto this trial, their T cells were collected. They were then engineered to express the new CAR specific for CD19. They could get additional myeloma therapy while that manufacturing process was going on. So that takes 3 to 4 weeks. And then they actually came in and were given another autologous stem cell transplant with a drug called melphalan, which is our usual chemotherapy that we use for transplant. And then about 12 to 14 days later, they got their engineered CAR T cells back. And then they were watched after that to see what the impact of that therapy was on their disease. Patients also had the ability, if they wanted to or if their doctor decided, to get lenalidomide, Revlimid, starting about 3 months after the transplant and T cells went in. So that was the basic design of the trial. And in terms of the results that were published, the paper that was in the New England Journal was really focusing on actually one of our first patients who were treated, who was very refractory resistant to therapies. She had had a transplant previously and progressed within the first 6 months. She had had almost all of the available myeloma therapies and was progressing on her most recent treatments. And somewhat amazingly, after she got her transplant followed by the CAR T cells, she went into a complete remission, which she had never really achieved with any of her prior treatments. And that complete remission has actually been sustained now for close to 15 months without any evidence of the disease coming back. She has been getting Revlimid sort of on an intermittent basis a couple times a week as her sort of only maintenance therapy right now. So that was the main focus of the paper, just because her disease, which was highly refractory and also had a lot of high-risk cytogenetic features, this response to this last treatment was better than any of her prior responses and better than I guess we might have expected just from doing a transplant alone.
So I think I want to highlight this because, I mean, I know you're very careful about, how you speak about your results and things. I know you don't want to be inflammatory at all. But for me as a patient, I read the paper, and this is a patient with deletion 17, with 1Q gain, with 95% of plasma cells being myeloma cells before she started the second transplant, with 9 other therapies that hadn't worked, including a recent monoclonal antibody. And you just say, wow. So I looked at the paper, and it has this little chart where it shows, the 2 doses of cyclophosphamide or whatnot that she got beforehand. Was that accurate?
That's
and
correct.
Then as soon as you gave the CAR T cell, and they kind of dipped and then went back up and dipped and went back up, and then it dropped completely to the bottom. So it's so significant because nothing else was working.
I agree. I think that this patient has had an amazing response, and it's incredibly exciting and incredibly promising. I think that's what got it published in the New England Journal. So I think you're right. Our natural tendency is to be conservative and say it's one patient and to not try to, as you say, over express the results here. But I think it certainly says something about the potential of this approach. And the other thing that I think was interesting, and just in terms of the hypotheses of why this might work, was that Al Garfall, who led the study, did a very detailed analysis of this patient's myeloma cells and the other cells in her bone marrow. And really, her myeloma cells, 99.9% of them did not express CD19. It was a tiny little percentage, 0.05%, were CD19 positive. So the majority of her cells would not be expected to be recognized by the CAR T cell. There was only this very small amount there. And so it really begs the question of what was this therapy doing and how exactly was it working. Certainly the high-dose melphalan given before the transplant was probably critical here to get rid of the bulk of those CD19 negative cells. And then the question is, did the CAR-19 cells work by eliminating that very small percentage of 19 positive cells, as well as there were other CD19 positive non-plasma cells that were in the environment. And there are some data that are emerging that even normal CD19 positive B cells or plasma cells that are not myeloma cells may have some immune suppressive effects in the setting of cancer, and so possibly taking out those cells with the CAR-19 cells may have helped and allowed the transplant to work better. And then, of course, there's this whole hypothesis, did we take out the myeloma precursor cell? And I think the answer is we don't know. We are trying to investigate that and do additional studies looking at these cells. So I think that may be, I guess, again, another promising way this might work if we can really demonstrate that those cells were present in the beginning and are no longer there.
So maybe let's go back to the stem cell clone idea for a minute, and let me just ask you, what does CD19 do? I know some of these proteins that are on top of the cells serve a certain function. So is there something specific that I know they were present in, mostly on all cells that you're looking at in the leukemias and lymphomas, and for these patients, they weren't there, or maybe the 0.05 that you're talking about. But what does CD19 do in general? I don't know.
So it's interesting. We really don't know the clear function of CD19, and it hasn't, at least, been demonstrated to have an important role in myeloma itself. It's more sort of a marker of B cells, which are the precursors to myeloma cells. But whether it actually has a function itself, I don't think is clearly known. And we don't think it's actually critical for the survival of the cells, because unfortunately we have seen in some of the acute lymphoblastic leukemia, or ALL patients, when their disease comes back, it has lost CD19 expression. So the cells, unfortunately, can learn to evade this therapy, at least in the other cancers, by dropping CD19. So it may not be critical for the survival of the cell. It rather just is sort of a marker that you can use to identify the cancer cell. And this is sort of an important point, because I think as we go forward trying to find targets to hit with CARs or antibodies, that it may be useful to try to identify targets where it's really critical for the cancer cell to survive, so that cell can't just lose expression of the cell to evade the treatment.
And then I think that's a really important point that you're making, because I have heard that from other people before, that the cells get smart enough to drop the signal, so they say, well, you can't attack me because I don't have the signal anymore, when they're going after a specific protein. In the leukemia and lymphoma work, did you, I know you're probably digging through all your data, but was there a way of telling who responded to, like you said, the 40 to 50% in CLL and 80 to 90% of patients in ALL were responding to these treatments? Is there any way of digging into why they're responding, or I'm sure you're looking at that.
So absolutely, and the leukemia group here is definitely looking at that, and David Porter, who's led the CLL studies, they've recently published a follow-up paper just a couple months ago with long-term data on their initial 14 CLL patients, and they really did try to see if there were any pre-treatment characteristics that could predict who was, destined to response and who was not. And they really did not find anything obvious that jumped out, at least pre-treatment, that could help you select patients. What they did find, and this has been predominantly in our experience at Penn, is that the longer the cells persist, the CAR T cells, after you've transferred them into the patient, that seems to be associated with better responses and more durable responses, at least in the CLL and ALL setting. And those patients who lost the T cells relatively quickly either had minimal responses or responses that really weren't durable, whereas the first patient in CLL who was treated over 4 years ago, you can still find these CAR T cells circulating, and the patient hasn't had any therapy since. So
they're sticking around, right, and still doing their job?
We think so. So we think persistence is important in those diseases. Now, it is interesting in the myeloma setting, at least so far, and again, we just have these first 10 patients that were published in the New England Journal paper. The CAR T cells don't seem to be sticking around indefinitely. Most of them, between 60 and 90 days, are starting to disappear, and we're seeing actually the patient's normal B cells starting to come back. So that's something I think we're very interested in trying to see if we can improve upon. in subsequent studies. Are there ways to get these cells to persist longer? Are there ways that we can maybe give multiple infusions of these cells? This initial protocol, the patients were all written just to get the cells one time, because it was really a safety experiment. We really needed to make sure that we could give these safely after a transplant, and I think we've shown that. But it's not clear, even in the one patient who was described in the New England Journal paper who's had this prolonged remission, she does not have detectable CAR T cells, at least right now, and that's different from the experience in the leukemias. So clearly there's differences in these diseases, and I think we really need more study to understand how they're working in different settings.
Do you think that the persistence issue might be because the leukemia and lymphoma patients have more CD19 present cells, and so I don't know. And in myeloma, they're not like a major target, and so they're persisting more in leukemia.
That's certainly
versus...
I think that's one of the leading hypotheses, and I think that certainly intuitively makes sense. So I think that's one possibility. The other is just the setting that these cells were given. They were given after stem cell transplant, and they were given 12 to 14 days after the transplant. And at that point, you're already starting to get recovery of the patient's white blood cells around day 12 or so, and so there may have been competition with the cells that were already recovering that perhaps affected the ability of the cells to persist. There may also be differences just in the bone marrow, it's called microenvironment, in myeloma that may be less hospitable to these transferred cells than in the other cancers. So I think these are really important research questions that will hopefully help us refine this therapy and understand how to use it. For now, though, I think we're just kind of come up with strategies to see how we might be able to get them to persist, either tinkering with the intrinsic signaling of the cells with the receptor itself, or perhaps giving them as multiple infusions for patients.
And let's talk about the administration of the CAR T cells and your timing, because I don't know what you did in leukemia and lymphoma, but it sounded like you may have tried it like immediately after transplant on other patients. Is that correct? And then you saw more of what you can maybe explain as cytokine release syndrome, or am I making that up?
No, not at all. That's absolutely correct. So actually, while this protocol was sort of being written and going through the regulatory approvals, there was a patient who was in dire straits with plasma cell leukemia, and so the team was able to get sort of compassionate use approval to treat this one patient even before this protocol was officially opened. And that patient, the way that it was originally given, the T cells were used actually at a 10-fold higher dose than what was eventually given in the protocol that's described in the New England Journal paper. And her T cells were given earlier, only day 2 after the stem cell transplant. And what we saw was that when given really that early after the high-dose chemotherapy and the stem cell infusion, there was a much greater expansion of these cells very rapidly. There was certainly greater toxicity, and particularly the patient did have what's come to be called cytokine release syndrome, which is now a well-recognized complication of these CAR T cells, where basically the cells just start dividing and growing and multiplying so fast, and as they're killing off cancerous cells, they are releasing cytokines or inflammatory markers, if you will, into the blood, and this sort of revs up the whole body's immune system. You could think of it almost as having the worst flu of your life, and in some cases it can even mimic sepsis, where the patients can become hypotensive, their blood pressure drops, they have difficulty breathing, they may have to go to the ICU. And so this can be very severe, and so that particular patient did develop more of that type of syndrome, as well as some neurologic changes, and this also has been described in the leukemia studies. She did eventually recover from those. Her disease did go into a remission initially, but then she ultimately progressed a few months later. So because of the toxicity seen with that initial patient, the subsequent patients were all treated later. The CAR T cells were given 12 or 14 days after the transplant, sort of separating it from the high-dose chemo, and also we gave a lower dose, a 10-fold lower dose of the cells. And so far, at least in the 10 patients treated, we have not seen this significant cytokine release syndrome. There's been one patient with very mild fever and cytokine release, but no one has had any severe toxicities. So I think by separating it out, we've certainly made it safer.
That's great.
And so I think we're learning more. Again, we don't know if 12 to 14 days is the best time. That's the time that was chosen, and there may be more studies that are trying to look at that timing.
And what about the use of a CAR cell therapy without transplant? When you look at the rationale to do the transplant first and then give the CAR, what is your plan? I mean, what are you trying to accomplish with the transplant as well?
Right. So the reason that this particular study was done with transplant was really because of the target in this case was the CD19 that we really thought was only going to be expressed on a small minority of cells. And so we felt we had to give it with something that had known activity against the bulk or majority of the myeloma plasma cells that may not have CD19, and especially you needed to control something to control the disease while those CAR T cells were growing and expanding in the patient. And so that's the reason we really decided to give it with a stem cell transplant in this setting. The high-dose chemo that's given before a transplant we thought could hopefully kill off a large proportion of the patient's myeloma cells and also give time for those CAR T cells to expand and grow and hopefully do their work. It's also now been shown in a number of studies that giving some type of chemotherapy before you transfer in T cells into patients does help those T cells expand and perhaps survive. So that was really the twofold reason for it. We felt we needed to do something to at least maintain some control of the disease and thought there may be a benefit of giving it with transplant. That doesn't mean you have to do it with transplant, and I think as we'll talk about later, our next trial that we've just opened with a different CAR is going to be without transplant. But I think there's reasons to explore both avenues.
Okay, well that's terrific. So before we move on to my another question that I have, do you want to talk about the other results? Because you have this very dramatic result with this one patient, and then you have very positive results with several other patients. Do you just want to share what those are?
Absolutely. So it's still very preliminary, but we have treated 10 patients, and this was described in the paper as well. So in addition to this first patient who's had a really dramatic response, we've had at least one other patient so far who's had what we call a remission inversion, meaning the time they got in remission after their second transplant was actually longer than the time they got after their first transplant. And that's something we really don't see very often in myeloma. Usually when you repeat the same therapy, it can work again, but many times it doesn't work for quite as long. So that also has been very encouraging. And so that patient hasn't gone into complete remission, but had a very good partial remission and was, again, progression-free longer than she was after her first transplant. We've also had several other patients who have had partial responses right now and remain progression-free, although, again, it's still relatively early. Some of these patients are only 2 or 3 months out from getting their therapy. And then, unfortunately, we have had at least 3 or 4 patients where it really didn't seem like it worked, and they did have progression within the first few months after the therapy. So clearly there's obviously still more we need to do and more room for improvement.
Well, in a past show, one of the doctors said that when you're working with these immunotherapies, there are kind of windows of opportunity to use them. Do you see that as well? And what do you see as the ideal window for something like this?
So I think, with most therapies in cancer, new treatments are often first done in patients who are very heavily pretreated. And especially for immunotherapies, that may not be the optimal time because the cumulative chemotherapy and everything they've had before may take its toll on their immune system, and therefore, if you're trying to utilize that immune system, it may not be the optimal time. So I think, ultimately, if safety is demonstrated in a larger population of patients, we would like to move earlier in the treatment course. And so you could imagine perhaps if this is going to be done in conjunction with transplant, maybe you could do this even with a first transplant rather than a second transplant, perhaps in high-risk patients who are high cytogenetic risk or other factors that may put them at higher risk for relapsing quickly after the transplant. So the hope is that, again, as we get more of a safety profile and feel more comfortable using this, that it would start to be moved up earlier.
Okay, that's great. And then, we were talking about it a little bit earlier. Let's just go back to that, about the stem cell clones, and because one of your second hypothesis was that it could be that the CD19 target might be killing off the stem cell clone cells. And you talked about, I had this written down so I would not forget it, but in your paper you talked about non-neoplastic CD19 cells. Are those just cells that don't have that CD19 target, or what are those?
Sure. So those are
is
cells
this related?
Right. So that was almost like that third hypothesis. So these are cells that they do actually express CD19, but they don't really appear related to the myeloma clone in any way. They are not expressing the same immunoglobulin or antibody on the surface of the cells that the myeloma cells do. They may just be normal, or at least normal appearing B cells, but they may be subverted in the environment of a cancer to now be immune suppressive. And this has been shown, at least in a couple of different cancers, more in solid tumors so far, that you can get infiltrations of these CD19 positive cells into the sort of environment around the tumor, where they act sort of as immune suppressants, and they block the ability of T cells to get in. And so again, this sort of is, I think, possibly a third hypothesis, not just targeting the main myeloma cells, not just targeting a possible myeloma stem cell or precursor, but actually just other bystander CD19 positive B cells that are in the environment, and whether those may be exerting a immune suppressive effect, and you're clearing those out, so it allows your therapies to work better. I think this one is sort of the, I guess, most hypothetical right now with the least amount of data. It's really extrapolating from some of the solid tumor data. But I think that was the point that was just brought out, that was another population that was seen in the bone marrow of this patient that was then potentially cleared out. So that's what was referred to by these non-neoplastic CD19 positive cells.
Oh, so they might just be there blocking treatment, and you're saying let's just clear the decks and move it forward.
Exactly. So that may be yet another way that this is working, separate from the whole stem cell hypothesis.
Okay. So with the stem cell hypothesis, we did a show very long ago where we talked about that, and that was the target. And I know maybe you want to explain the controversy to us as patients, and how we find out, is the detection there to be able to even detect at this point what we can, even with all the new MRD testing and all that? How do you determine where the stem cell clones are, if they're there, and how do we dig deeper into this disease, I guess? Sure.
So it's a great question, and as you mentioned, it is controversial. There are those who really believe that myeloma stem cells exist, and there are some that believe that they really haven't been conclusively proven to exist. And what I guess people are talking about is that, as you know, when myeloma patients are treated, we're usually very successful in the beginning at getting rid of the myeloma cells, and we can get their M spike down and get them into remission, but the disease inevitably relapses, unfortunately, in most patients. And the thought perhaps is that there is some chemo-resistant cell that gives rise, and again, to the entire tumor population of myeloma cells, even after the patients have gone through their treatment and appear to be in a great remission. And so people have been trying now for years to try to identify where is that cell, and is that cell truly what we call a stem cell, a cell that's capable of what's called self-renewal indefinitely, that it is just very difficult to get rid of and can just continue to divide and give rise to the rest of the tumor. And so there have been studies now dating back over 15 years suggesting that the myeloma stem cell, if it exists, may not have the classic features of other myeloma cells. There's a marker called CD138 that's usually expressed on myeloma cells, and yet in some original studies done by Bill Matsui at Hopkins and others, they found that you could actually recapitulate a myeloma in a mouse, not using the CD138 positive cells, the bulk of the myeloma cells, but a small population of cells that didn't express the CD138 and expressed more B cell features, CD19. So that was the first sort of idea that perhaps CD19 might be a marker for a myeloma stem cell. However, subsequent papers did not reproduce those results, and there's been this back and forth controversy really wondering whether there is a true myeloma stem cell or not. I think what is clear, at least in most recent studies, is that there's something called plasticity in the markers that are on the surface of myeloma cells. That myeloma cells can look one way early in a patient's disease and then after a patient's been treated, there's actually an evolution, and the myeloma cells can acquire additional features, and in some cases that features include more of a B cell or CD19 positive phenotype, and that's often associated with being more resistant to treatment like bortezomib or Velcade or treatment with chemotherapy. So the treatment-resistant cell may be a CD19 positive cell. So it's a little complicated to explain, and I'm not sure if this is helping or not.
No, it does.
I think regardless of whether you believe these are truly stem cells that are immortal and can give rise to everything, or they're just a sort of reservoir of drug-resistant cells that happen to express CD19, and the cells are just interchanging back and forth. Either way, I think there is rationale to try to target these cells. It makes sense to potentially hit the disease with more than just our current therapies, but think about ways to perhaps hit these myeloma precursors that may be more resistant. And so this is one approach to doing that. And hopefully there will be others as people seek to understand a little bit more about them.
Okay, well that takes us into a great topic of combinations and combination therapies, and maybe you want to just give us some insight about where you're headed next. Now that you've done this with leukemia and lymphomas and you had success in some myeloma patients with this target, where are you going next?
Sure. So I think with the CART19, that's still a bit up in the air. As I mentioned, one idea would be to take it earlier, patients perhaps getting a first transplant but are at high risk of relapse. So that would be one idea. And then the other is really to look at other targets that might be expressed on a larger proportion of the patient's myeloma cells, and therefore potentially could be used by itself without the transplant. And so that is certainly where we have started to go next. And we have just recently opened a second study using a different CAR that's specific for a molecule called BCMA, or B-cell maturation antigen. And this has been identified as being expressed on normal plasma cells, but also very highly expressed on malignant plasma cells or myeloma cells, and seems to be expressed in almost all the myeloma cells that have been tested, both cell lines and patient samples. And importantly, it's not really expressed on a large amount of other cells in the body. It's on some mature B cells, but otherwise seems like a relatively safe molecule to target. So based on some, again, early preclinical studies and mouse studies, again, the group here led by Carl June and Mike Malone and others in collaboration with Novartis have actually developed a CAR against BCMA. And so we are now just starting a study where we're going to be giving these BCMA-specific CAR T cells in patients with relapsed refractory myeloma. And again, I'll state we're certainly not the only ones doing this. The group at the National Cancer Institute has been doing this as well and has a study targeting BCMA, and I know there are others in development as well. But that particular study is going to be, again, for patients who have multiple myeloma that has relapsed or come back after at least two or three other lines of treatment. But this one, importantly, is not involving a stem cell transplant. So the first group of patients are just getting the T cells alone, and we're assessing them, again, just for safety. And then if that does appear safe, there are additional cohorts that may get the cells in combination with Cytoxan, a chemotherapy agent that we think can help the T cells expand. So that's the current study, and we're just getting started with that now.
And as part of this, so that's great to hear that you have another trial coming up. And when does that open, or is it already open?
It just opened, actually, in the last couple of weeks. So we haven't treated anyone yet, but we are sort of getting underway at this time.
Oh, okay. Well, that's great. Well, we'd be happy to share that on our website. So in CAR T cells, this is an engineering process. And when you look at companies that are typical drug companies, they're providing some kind of medication. But this is an actual engineering process, right? So someone like Novartis or someone else might, they're working on the engineering process. That's what they're providing?
So the process itself was generally developed and sort of perfected in the individual academic institutions. I think what the companies are doing are really trying to expand that to large-scale production, because I think that's probably the only way it's ever going to get out of just one or two institutions and get to be widely available, because they have the ability for distribution to do that. So I guess it's a partnership. They're taking, I guess, what was developed at these institutions and then are going to try to scale it up and actually try to provide it and make it available like a drug. And again, I don't honestly know quite yet how the logistics of that are going to work, but I know, at least in leukemias, that we have started some multi-center studies, so where these cells are not just given it to people at Penn, but are being manufactured and then shipped to other sites where they then can be given at the local center. And I think that's the ultimate goal, is that a patient will be able to go to any of their local transplant centers or myeloma hospitals, have their T cells collected, shipped out, they get manufactured with the card, and then they get shipped back where they can be administered by the local physician, so that patients won't have to travel just to one site for this. I think that's the ultimate goal. But how close we are to that, I guess I'm not sure yet.
Well, that's what I'm sure they're working on quickly.
Absolutely.
to be able to provide that.
Absolutely.
So I know that there are other CAR T-cell targets, and you were talking earlier about just different B-cell markers like CS1 and BCMA. Why did you choose BCMA over another one?
So it was primarily because of the expression pattern seemed most favorable in terms of a safety profile. I think one of the things about choosing a target and making these cells is that these cells can be very potent, and once they're in the patient, if they see their target, they just start to grow and grow, and it can be you just have to be very careful, I think, about where you're going to target, because if other cells are expressing that same target, the T cells could start to attack them, and then that could lead to collateral damage. So BCMA seemed to have a favorable expression profile in that it was really largely expressed on plasma cells, particularly malignant plasma cells, and again, a small subset of B cells, but really not on lung cells or blood vessel cells or intestinal tract or other places where you think you might get toxicity. So we thought both it might be a good way to target the plasma cells and kill those off, and then potentially not have more off-target toxicity. It's certainly not the only target, and you mentioned CS1, also known as SLAM-F7, and that one certainly is also being explored by several centers, and the group at Ohio State has published about CS1 targeted CAR T cells, and I believe it's working on a clinical trial as well. And there are others that I know are in clinical development. There's a group in China that's doing a CD138 targeted CAR. A group at Baylor is looking at a CAR targeting kappa light chain, which is expressed in 2/3 of myeloma patients. So again, hopefully there'll be a lot of these out there, and we'll be able, after hopefully another year or so, to have some at least preliminary data on multiple approaches to get a sense of what might be safe and efficacious.
And an extension of that would, if you look at the CD19 and you say, well, part of the purpose is that it might be just clearing things out so other treatments can work. I know you probably can't answer this right now, but could you hypothetically use, the CD19 CAR with the BCMA CAR with a kappa light chain CAR and just say, okay, we're going to go for 4 targets, and you'll probably test for safety, I'm sure, before you do this, but would that work? Because then when people tell me that the average patient has 5 different myeloma clones on diagnosis, then you just think, as a patient, you're just thinking, okay, just kill it all, right? Kill it all.
Right. So I think that actually makes really great sense, and I do think there will be studies that are combining these together. And so I think once you show you have safety of each one individually, then you can start to come up with ways to use them together. And I think BCMA and CD19 make a lot of sense because they may potentially be hitting different populations of cells that could actually synergize and lead to greater eradication of the different clones. So again, I think it's all theoretical right now, but I do think we'll start to see combination CAR cell therapies. And as the technology improves to manufacture the vectors, you could even imagine, even in one cell having receptors that can target two different molecules in the same cell, and then you can potentially, make it easier just to put in one group of cells with different markers. So I think there's a lot of opportunity here to combine with CAR T cells together, and then also certainly combining with other, myeloma therapies, other immunotherapies. I think all of these things are probably going to be coming.
Yeah, that's, I guess, my next question is there's so many more, you have the monoclonal antibodies that are almost or getting close to being approved, and then you have the current drugs that still have anti-myeloma effects. So how will you as a doctor decide what to use and when? And I mean, sometimes you learn more from things that don't work than things that do, and is there any learning that you can garner from the people for whom the CAR T cell stuff didn't work initially that you might want to combine with something else?
Yeah, so in the 10 patients so far, I think we're still analyzing that data and trying to understand who is likely to respond and who is not. And with a small number of patients, it may be hard to tease that out. But I don't think there's anything that's jumped out quite yet. Again, one thing we mentioned is the cells aren't persisting quite as long in this setting as they were in the other cancers, and so trying to enhance the persistence of the cells, I think, would be one thing. Certainly we know that the immunomodulatory drugs, lenalidomide and pomalidomide, that these cells have actually the ability to stimulate T cells, and so that's sort of a logical combination to potentially use with these cells. And then I think there's a whole host of novel immune checkpoint inhibitors that are being tested in other cancers, but also being tested in myeloma, particularly PD-1 inhibitors that, again, may enhance the ability of T cells to be effective and to live longer. And so that, to me, also sounds like a natural combination. And a lot of this, I think, is being tested in the laboratory right now, so our scientific colleagues are really going to help guide us here because they may be able to test multiple combinations, and then we can take the ones that are most promising and bring that to the clinic and do clinical trials.
And how do you shorten up that time frame? I mean, it's so difficult, I think, for you as a researcher to say, okay, I have to test safety first, obviously, and then I test it in a larger group of patients, and I'm going for efficacy, and then I have my phase 3 trial. That all takes time. And, there's so many exciting things happening. Are there different strategies that you can see that might shorten up that time frame with especially all these new immunotherapies?
It's a really great question, and it's a big problem, and not just in myeloma, in all cancers, I think, is patients obviously desperately need new treatments, and we want to try to get those treatments into the clinic as quickly as we can, but obviously we need to do so safely and make sure that what we're doing seems safe. So I don't know that I have an easy answer. I think that what's happening with the CAR T cells, where there's an industry partner that's starting to get involved fairly early on with the academic centers, may help, because I think that allows it to scale up faster than probably one center could do on its own. So that model, I guess, which is still relatively new but is happening now, I think, with a couple different centers, may allow this to become more widely available, at least the CAR T cell technology. And then in terms of combining with other agents, some of that is related to just being able to get the drugs and get companies being willing to combine their drugs together. But I do think there's a little bit more willingness, especially with these immunologic agents, since they, like the PD-1 inhibitors, seem to have a pretty good safety profile. And so I think there's been willingness to combine them together. And I know of a number of studies of those antibodies going on in myeloma right now, combined with lenalidomide or pomalidomide. And I think, again, as we get safety data from those combos, you could imagine now maybe I can add a CAR T cell in with that and see if I can really get a great immune response against the myeloma. So I think they'll happen. I know it never seems fast enough, but I do think we are trying to move these things into the clinic as quickly as we can.
Well, I know you're working hard. Everyone, we're just so grateful that there are such brilliant people like you out there thinking about myeloma every day, so we're really thankful.
Thanks.
I have one final question before I open it up to caller questions. And I know that I started this series with the intent to help patients understand clinical trials so that they could join in greater numbers, because the number of people that join myeloma clinical trials is very small. It's like 3 to 5%. So from your perspective as a researcher who's trying to move things down the road at a faster pace, do you have any words of advice for us as patients about clinical trials?
Yeah, so I think clinical trials are crucial and critical to advance the field and help get these new treatments to patients. And so I think it's always worth asking your physician if there might be a clinical trial available when he or she is talking to you about your initial treatment. There are all sorts of clinical trials, from phase 1 trials that are really new that might only be available to a specialized center, all the way up to phase 2 or 3 trials with agents that have more proven track record and might be available in a general oncology practice. And so I think patients, as you I'm sure have always said, patients should be their best advocate. And so one, ask if there are trials available, and if the doctor doesn't know, then you can certainly go on websites for any of the academic centers in the region, and they usually have an easily searchable list of what trials might be available. I'm sure your website will also have links to different places that may allow patients to find trials. Clinicaltrials.gov is a little bit tricky sometimes in searching to try to identify a trial that might be right for you. So, but if there is one you're looking for there's almost always at the bottom of clinicaltrials.gov page a contact number for that particular study that you can reach out to. So I think all of these things hopefully can help you find the trial that might be right for you. Okay, great.
I want to mention, too, that we just added a new feature to our site, and we're partnering with a group called Spark Cures. And they have created a very simple clinical trial finder that if you go to the Myeloma Crowd site and you click on popular links, the top link will say Find a Myeloma Clinical Trial. So they've taken all, like the ECOG studies and all the open myeloma clinical trials, and you can search for them based on the type of therapy or based on your disease state. And it's a very simple, easy to find tool. It's a really great tool.
That sounds great. I think that's exactly what's needed.
So, Dr. Cohen, we're just so grateful. I would like to open it up for caller questions. So if you have a question for Dr. Cohen, please call 347-637-2631, and then make sure you press 1 on your keypad. So our first question is at 763-5738. Go ahead with your question.
Hi, thank you for taking my call. So I'm a myeloma patient. I'm almost 4 years out, and I just got into a clinical trial about a month ago, so we're not sure how that's going yet, but we'll know soon. And I just want to make an overall comment that I almost had to beg my doctor to get into a clinical trial. So for all of you patients out there, don't give up. A lot of times, and I'm not sure why, there are many physicians or treating offices that are very hesitant to try a clinical trial. So I went in armed with many clinical trials that I thought might be good for me, and I started rattling them off, and then I got into one. So with that in mind, I'm wondering how we would go about, I'm sure that there are many patients who are interested in these clinical trials that you've been discussing this afternoon, and how would we go about finding them, and what is the commitment? Where would one need to travel? How much would that cost if your insurance doesn't cover it? Can you give us a little bit more information about that?
So I can say I think I'm not supposed to actually sort of advertise or recruit for our trial in this forum. So what all I can really say for the Penn study at least is that you can go on clinicaltrials.gov and look up CART BCMA for myeloma, and then there is contact information there that you can use to call, and then somebody can get back to you and give you information about the study. Most of the CAR T-cell trials are fairly intensive in terms of time commitment in the beginning. And again, it may vary from trial to trial, but most of them you need to be in the location where the T-cells were given for a few weeks after the study, just because there's very close monitoring and follow-up for safety. And after that, it becomes less onerous. Other trials, I think it really just depends on the nature of the study. There are some studies now just with all oral agents where you may only need to be, coming in once a month, where other ones where it's intravenous or it's an earlier phase study, there may be more time commitment. In terms of reimbursement, that also is sort of study dependent. Some studies, there is built in some cost for travel expenses, and some are not. And I think, unfortunately, you just have to ask the coordinator for that individual study. So I know it's unfortunately not as easy as it should be, and I think these like the program that Jenny described for her website, I think is going to be very helpful, because it might be one area where you can search. And then I think once you find the trials that sound interesting, you just have to reach out individually to each study and talk to the coordinator there, and they can give you more details, because it does vary from trial to trial.
Thank you. I mean, it's sometimes disheartening as a patient to be navigating, trying to get into your own different clinical trials when we're not even feeling that great. So someday, hopefully, it'll be a little bit easier. But thank you for your time. It's been a great interview.
Thanks for your call.
Okay, thank you so much. And our next caller is at 889-4902. Go ahead with your question.
Hi, doctor. I just wanted to ask you, how long do you think it will be until this type of treatment is available for newly diagnosed patients?
So for the CAR T cells, I do think it's going to be a little while, to be honest, just because there are risks and toxicities associated with these approaches. And there are so many treatments that do work right now in myeloma. So for newly diagnosed patients, I'd be a little hesitant to try something like this that hasn't yet been proven. But my hope is if we do have more data in another year or two, and especially if it seems safe, then you'll start to see studies going forward in, I guess, less heavily pretreated patients. But I don't see that, at least right, in the near future right now, at least until we have more data.
Thank you. I appreciate you taking my call.
Sure.
Okay, great. And a follow-up question I have that I think will be our last question is, have you found any strategies to minimize any potential side effects from the treatment?
So one thing we've learned in at least with cytokine release syndrome, and this has been learned in all the leukemia studies, is that you can actually treat that cytokine release syndrome with a drug called tocilizumab, which is actually a drug approved for rheumatoid arthritis. But it basically blocks signaling through a particular receptor called IL-6 receptor, and IL-6 is a cytokine that's very involved in the cytokine release syndrome, and if you can block it with that drug, you can get significant improvement, and doesn't seem to affect the ability of the T cells to still work. So that's been one very useful lesson that's been learned from the early studies, and that's something that we certainly use when we start to see severe cytokine release in our patients. That we can usually abrogate it with that particular drug.
Okay, great. Well, Dr. Cohen, we're just so grateful that you joined us today. We're thrilled to learn more detail. We're very excited about your results, and we wish you just Godspeed as you keep working.
Absolutely. No, thanks again for having me on. I really appreciate it.
Oh, well, we're just so thankful. So we just say go. Go to you and keep going.
We certainly will.
Okay. Thank you so much. And thank you for listening to Myeloma Crowd Radio and the new ways that patients can help support the discovery of a cure through the Myeloma Crowd Research Initiative. We encourage you to become involved.
It is Ryan here, and I have a question for you. What do you do when you win? Like, are you a fist pumper, a woohooer, a hand clapper, a high fiver? I kind of like the high five, but if you want to hone in on those winning moves, check out Chumba Casino. At ChumbaCasino.com, choose from hundreds of social casino-style games for your chance to redeem serious cash prizes. There are new game releases weekly, plus free daily bonuses, so don't wait. Start having the most fun ever at ChumbaCasino.com.
No purchase necessary. VGW Group. Void where prohibited by law. See terms and conditions. 18+.